All right, thank you everybody. So we are going to transition now into sort of what therapeutic risk assessment actually looks like in clinical practice. So we talked a lot about the benefits of it and why you should do it in terms of patient care and sort of self-care, but what does that look like in actual clinical practice? So there's really 4 main elements to it, and we're going to be covering each of these in a lot of detail. So starting with just suicide risk assessment, so the basics, that's sort of the core of this model. How we do suicide risk assessment, this is the first time actually I've done this. I've taken sort of some of the stuff that we've done and I try to integrate it with the clinical practice guidelines that have just come out on suicide. How many people have looked at the clinical practice guidelines? Okay, you. I have to admit it's a pretty cumbersome document. It's over 180 pages. It covers quite a bit. Really going to be focusing on one aspect of that today, which is the suicide risk assessment component of it. And sort of really trying to break it down into sort of the key practices and the key recommendations that you should be focusing on in your work with patients. Also talking about how we can use measures, self-report measures, psychological measures to augment our practices and how that really helps us take care of ourselves again, support our documentation, and how we actually can integrate that with our conceptualization of the patient's level of risk, and going into how we actually determine level of risk. So what are some of the most challenging things about doing suicide risk assessment for people? You know, there's many things, but if people can just sort of blurt out some of the things that they find most challenging. Yeah. Doing suicide risk over the phone, okay, great, that's good. Okay.
Already having other things on the schedule that decrease available time.
Time, okay, time, that's a great one. You know, that's something that comes up quite a bit, to do a thorough evaluation, sign of time, okay?
Just differentiating between a chronic, a person with chronic suicidal thoughts and a kind of a change in status in that way.
Great one, and that in particular comes up quite a bit, and that is really what we're going to address a lot. So we're going to address how do you take a lot of information to formulate a risk, and then how are you looking at risk? Are you looking at it in the moment? Are you looking at it over a course of someone's lifetime? And what do you as a clinician need to be concerned about when you're meeting with patients, and just sort of how you feel sort of secure about them leaving your office for that day, for that appointment. And I think, again, we've alluded to this several times. It doesn't matter if you're doing the best things, the right things. If you're not documenting it, that's a problem. So how can we take all of this again and document it in a way that's feasible? It doesn't take a lot of time, and you can just easily incorporate it in your practice. And then we're going to get into a lot about interventions, but the intervention that we're going to really hone in and focus on today is safety planning, and how a well-documented safety plan that you do in collaboration with your patient can be sort of the single best intervention that we really have available today, that can be sort of more implemented, sort of, more widespread implementation across different levels of risk in different patients. So the components of suicide risk assessment, I mean, some of this information is not going to be new to folks here. I mean, this is part of what you do. This is part of your practice. I think what I really hope to get out of this is to show you how these are aligned with sort of what are now the clinical practice guidelines. We never really had, I would say, a standardized sort of best practice structured format for how to do this. And so I think the clinical practice guidelines do a pretty good job of actually trying to make that more standardized. But there's a lot of components to it, so how can we take that? What are the key elements that you need to be really focused on that you can do in a pretty reasonable amount of time? Some things just going into this to be aware of, and just to sort of, more of a, not a disclaimer, but just to really highlight is suicide is hard because it's a pretty rare event. And when we think about like all the other things that we deal with as clinicians, suicide, the actual behavior, doesn't happen very often. So it makes predicting it, very difficult. Along those lines, prediction is what we're not trying to do with risk assessment. And I think a lot of times that gets confused. We're just trying to identify people who are at risk for engaging in suicidal behavior, but to actually predict who will go on to die by suicide is a task that we are, really quite far from at this point. Structured scales, I'm going to talk about measures that are available in CPRS and actually go through some of those measures and how you can incorporate them in your risk assessment that are available. You can use, they're not to be used as standalone instruments to determine level of risk, but they can really help augment your conceptualization, just the clinical interview part of the risk assessment. And again, it's something that you can add to your documentation to support sort of your determination. And even if we had some formula for where we could punch in, a bunch of factors and numbers where it would say, this person's level of risk is, this, they're in the top, 1 percentile of, individuals who may then go on to engage in suicidal behavior. Those really don't tell us what we should be focusing on in treatment. So, what are the underlying things that are contributing to risk? They differ for different people, and what should we be targeting in treatment to lower individuals' risks? So some of the just guiding principles in general. Standard of care does require sort of a clinical assessment of risk, but what that actually entails varies significantly across providers. Some of the best practices out there really not only focus on indicators of suicide risk, so do you have thoughts of suicide? Do you have intentions to act on those thoughts? Do you have a plan? Do you have access? But they go into sort of a more comprehensive evaluation of people's sort of like underlying risk factors, psychiatric illness, what's going on in their life at that time, other stressors, psychosocial factors. So thinking about, all those other risk factors that can really help, modify your conceptualization of that person's level of risk. And then also protective factors, which is something that I think generally speaking, we spend less time focusing on. So if someone has a certain level of risk, but they also have a lot of support, a lot of protective factors, how does that actually change your determination of their level of risk at that time? So again, we'll be talking about how you balance these two things as well. And then also, I think the most important thing is that it's just not something you do one time. It's a process, it's ongoing, it changes, it's dynamic. Something that could be a risk factor could actually then end up being a protective factor. Relationships is a big one. If relationships are supportive, they can be really, really helpful. If there's conflict in a relationship, that can change something into more of a risk factor. But really trying to talk about the sort of dynamic nature of risk and protective factors. Okay, the VA-DoD clinical practice guidelines. So back in, I want to say 2009, the DoD task force really kind of came up with this idea that we have clinical practice guidelines for PTSD, we have clinical practice guidelines for depression, we even have clinical practice guidelines for concussion and some comorbid conditions, but we don't really have clinical practice guidelines for this huge area that is really challenging for a lot of clinicians and a very, very important part of what we do. So they got together a task force, and one of the objectives of that, there were a number of different objectives, but one of them was to kind of come up with clinical practice guidelines for suicide risk assessment and management. And that, a couple of members of the MIREC were involved in that. We worked with the DoD. This, happened over a course of a few years. Started with doing a really systematic review of what's out there, and there's really not much out there in terms of sort of evidence for how you do this. But basically, taking into consideration experts and what the literature does say, they came up with clinical practice guidelines. And what this area covers, what it's really intended to do is kind of like reduce sort of variability in practice across providers to come up sort of with a more standardized set of recommendations and practice guidelines that people can actually use in their everyday practice. And also kind of provide at least the most evidence-based interventions that people could be using to reduce risk in their patients. So again, it covers quite a bit. It covers, ranging from like who you even should be assessing risk in, from how you do that, to how you stratify a risk, to how you manage it. Another really interesting piece of this is that it really does focus on not just mental health and behavioral health providers, but primary care as well. Because that, for a lot of our veterans, is the main point of access into the VA. So how can we be doing that also in primary care, and then how does that transition to then those who actually may need more specialty services, mental health services? So it's actually broken down into 4 modules. The whole document, I think, is like over 180 pages. And it's really, it's a lot to read, it's a lot to take in. There's a lot of sort of offshoots. You have main sort of principles and practices, and then each of those are broken down into a lot of different sections. Again, I would encourage you just to look, over them, just to get an idea of sort of all the different things that it covers, but really trying to condense it for everyone here and just break it down to sort of really the key principles that we can take away from that. But we're really going to be focusing on Module A. We're going to get into some of the other modules, but very specific practices in all the other modules. Safety planning, for example, is going to be in Module C. And we're going to be really spending the good portion of the afternoon going over that, but really for this portion of it, really focusing on risk assessment. Okay, so what the next few slides are going to sort of look like. On the left-hand side, you'll see sort of maybe key decision points or practice recommendations that I kind of just put out there based on sort of this idea of therapeutic risk management and this model, and then showing you actually how that maps onto the clinical practice guidelines. So the clinical practice guidelines has a number of different what they call annotations or sections within risk management. So section A or annotation A is how do you even determine who you're going to assess risk for? Who is going to get a comprehensive risk assessment? When someone comes into your practice, how do you know whether you should even initiate those processes? So that's sort of where we're going to start here. And really what the guidelines say is that anybody who could be a possible risk. So that's leaves it really wide open. It does give you some criteria for what that might be, and I know they're cut off, but there's a lot of things that we do in the VA that can actually help us hone in on this. Our clinical reminders, depression in particular. We do a universal screen for depression called a PHQ-9. It has an item on there about suicide. If that is triggered, that can then actually let you know who you need to be initiating the rest of the risk assessment processes for. If they screen positive for other diagnoses, and depending on their history, if they're presenting to you with, either what we call passive, thoughts of just wanting to be dead, or actual suicidal ideation, these are all things, obviously, that would trigger a more comprehensive evaluation. And I think it's different when someone's coming to you for the first time versus you knowing them and you knowing their history. But I think a lot of it also comes down to clinical judgment. If there's anything that is sort of indicating that this person may be at risk, then that would actually trigger what we would call the sort of more comprehensive evaluation. I touched on this a little bit, screening. Screening can, again, be helpful for, identifying those who may need more assessment. It's not diagnostic. It's not to be sort of replaced with assessment itself. And you'll see sort of the difference between sort of, what we sort of consider screening and the actual assessment process. But there are some things, again, in place at the VA that can help us with this universally. I would say it's the depression screen that everyone's really required to get. There's the item on there that does assess sort of suicidal ideation. We've touched on this, and I think this is not news to anyone. This is something that, everyone's doing on a ongoing basis and is thinking about with their patients on an ongoing basis, especially those patients that are at risk. But it's a process that changes, on someone's level of risk. It's fluid. It can be high and then, go down to being sort of more intermediate or low. But we want to be tracking it, and we want to be tracking it on an ongoing basis. And like Lisa referred earlier, sort of the benefits of having a nomenclature actually allows us to be using the same terms sort of on a consistent basis in our own practice, but having sort of somewhat of a structured way to approach this also helps us remain consistent. Make sure that each time we're doing this, we're doing it sort of in this sort of same way. We're covering all the areas that we need to be covering, and we're actually determining someone's level of risk in the same way. We're not like using, one or two factors the first time, and then, that equals someone has high risk, and then another time we're just, taking all these other things into consideration. We need to be kind of having sort of somewhat of a structured way to look at this, so we know we're asking the right questions, but also allow flexibility for each individual patient. Okay, so the first, once you identify who you need to be assessing risk for, the next part is really looking at what does that entail. So to sort of really, I guess, somewhat simplify what actually goes into sort of risk assessment, we're really going to be talking about, first part of it is just gathering information. What kinds of information do you need to gather in order to make an assessment of someone's level of risk? So it all comes down to gathering information, integrating that information to determine someone's level of risk, and based on that, intervening. There's different types of interventions depending on different levels of risk. So you want to really get down to what that level of risk is in that particular moment in time. So these different modules that you'll see on the right, or annotations, again, are sections of the CPG that basically reflect these practices. So first, starting with assessment of suicidal ideation, intent, and behavior. That's the first part of that. That's sort of some of the most critical information that we want to gather. And those are like specific indicators of suicide risk. There's those, and then there's things that we want to consider that's really going to help us determine someone's level of risk that are not specific questions about suicide. And those are sort of what we generally refer to as other types of warning signs, risk and protective factors. And how do we integrate that information with this other suicide-specific information, and again, determine the level of risk, and then what does that mean for what we're going to be doing with that patient in that session at that time, and sort of moving forward in treatment. So what are some things that people assess or ask about? What are some questions that people ask when they're trying to get at suicidal thoughts? Either questions that you ask or other methods that you use. What are people generally doing in practice? This is specific to you, so feel free to throw some things out there. Hopelessness, great. Okay. And do you just ask that, or do you give a measure?
There's a question on the scale, and then also just ask.
Great. Okay. Yes.
I'll just try to get a sense of what they see on the other side of this crisis, or do they see the other side of this crisis?
Okay.
Get better, or well.
Great. So tuning into what they're experiencing, the crisis at that point in time, and trying to get them to get a sense of whether this is so this is a time limited thing. This is a temporary kind of thing. Yes.
For people who have a history of just chronic suicidal ideation, like it's always there, I try to assess to see if what they're experiencing currently is any different from how they do normally.
Great. So getting it, how does this differ from your baseline? If you always have thoughts of suicide, how is this different than sort of what your normal, great, okay.
Have you felt like this before, and was it close to outcome previously?
Okay. Great. And so how, have you felt this way before, asking them specifically about thoughts that they're having?
Yeah,
with
so
suicide?
whether that's to either how they were able to resolve, or whether there was intervention, or
Okay, great. Do people have a general process that they go through? Like starting, you know, kind of asking certain specific questions and then based on those answers move to, or do they just, is it sort of just based on your clinical experience through the years, you kind of just take each case sort of in a different approach? Do people have a sort of a built-in process for themselves that they use? Both. Okay. All right. Okay. All right. So part of what I think we're going to get at here is kind of giving a little bit of a structure, a process that you could use potentially with every patient that where you would need to do a suicide risk assessment for, but again, allowing some flexibility based on sort of what each patient uniquely brings to the situation. I think one of the most important things to get at is we're not using this like really rote checklist approach where we just kind of, are you having thoughts of suicide? Yes, no, okay, moving on. Suicidal ideation is sort of one aspect of it, but it's not the end all be all. As we kind of have gone over before when we were talking about the nomenclature, we really want to be getting at intent. Particularly for those individuals who always have thoughts of suicide, we want to know kind of a little bit more about the nature of those thoughts, because that's going to help us sort of, again, determine sort of where they're at compared to their baseline. You know, how often are they having them? Is it something where they get it and it kind of goes away pretty fast, or is it just, you know, persistent and just keeps getting, you know, more and more intense over like the next few hours or days? Is it something where they are distressed by them, or does it actually give them a little bit of comfort? I mean, that is something that varies a lot across people. Some actually find suicidal thoughts comforting because it's like, well, no matter how bad things get in my life, there's always something that I can do. I have ultimate control, and I can, you know, end my pain. So in some ways, it can be comforting to people. In other instances, people are really, really distressed by them. Why am I having these thoughts? What does that mean? Does that mean that I have to actually act on them? So I think finding out a little bit more about the nature and the duration, and again, sort of how people respond sort of when they have those thoughts is really important. This template, if anything, I know we've said that a lot. If there's anything you can take away or remember from this, this should be it, but this is one of those as well. So I think this is the CPG broken down into one slide, one box. If you have to remember anything from this, and you can say, like, I pretty much know how to implement the main key components of the CPGs, Module A, it's doing this. So this is kind of the first part. So if you really want to start by getting at those indicators of suicide risk that are more direct, where we're really asking people about different sort of aspects related to suicide, this is sort of that first portion of it. So we want to start with ideation, asking them about what are their current thoughts of ideation, and again, not just stopping at, and I'm going to go through each of these, break each of these down sort of in more detail. So ideation and intent. So are you having thoughts of suicide, and what is sort of the intention of acting on those thoughts? Plan, do they have a plan? Sometimes it actually, the CPGs have it outlined in sort of this order, but I actually sometimes find it easy to ask about plan and then ask about sort of people's intentions of like acting on those plans. And that somehow tends to flow a little better in practice, but I think the idea is also getting at sort of, if they're intending to sort of engage in behavior, how are they basically planning on doing that? Do they have sort of a general idea of a method, or do they have a really detailed plan that they've already sort of put together? And then, do they have access to means either related to their specific plan or just other access to means in general? and then what can you do about that. A lot of our sort of more immediate interventions are going to be really highlighting this last portion, and we'll be really going over that in the safety planning part. So for ideation, I think one of the key points is just be really direct, ask very directly if the individual is having thoughts of suicide. I think there's different ways that we can ask this, and I think just depending on individuals' levels of comfort, might ask it in a non-direct way, but I think we want to be very, very clear. I think the more comfort we have with this, that shows with our patients. If we are kind of skirting around the issue, if we're avoiding it, that gives a sense that there's something that's not okay to talk about. And I think that one of the best things is, again, normalizing that probably at some point in everyone's lives, this suicidal thoughts in some way or other may have come up, whether again it's passive, I wish I was dead, or something that's more sort of intentional, like I want to kill myself. But I think that this Steve Hayes, and most of you know who Steve Hayes is, really just the founder of acceptance and commitment therapy. He likes to really say this quite a bit. I think everything that every training that I've gone to with him, where he really comments on, just really normalizes suicidal thoughts and ideation, and how that's really different from actually engaging in the behavior. So what are some things that we can ask to get at that are just really specific and direct? The CPGs have a lot of just different examples of how we can frame the question. What are some things that people here ask?
You ever think about harming yourself?
Okay, great. Good. Others, I know people have asked this question a lot. Okay, great. Yes. Okay. Yes. Are you feeling suicidal? Are you having thoughts of ending your life? So getting to the content directly without using the word suicide is having thoughts of ending your life. Great. That's perfect. Yes.
I work with older people, a lot of them who are very sick in their life, and I'll ask them if they're about hastening their own death.
Thought about hastening their own death. Very good. That's great, and that's I think really for the state of Washington too. We're going to get at some of that at the end of sort of not this section, but at the end of the safety planning section. But that's a really good one. Are you feeling like you'd rather be dead? Good. These are all great. Are you feeling like you want to hurt yourself? Okay, so keeping it really, starting really broad, and then, okay, that's good. All of these different ways are just different, people respond to different types of questions, but I think all of these different ways of asking it can really help, get some people might not really be thinking about suicide, but if you ask them, are you, thinking of hurting yourself, that might pull some information from people that it wouldn't normally. So especially since it is, I think, difficult for some people to disclose this, finding different ways that you can get at it directly is really just, again, having more tools in your tool belt, having different options. As far as just kind of getting a really comprehensive idea of what the ideation is like, again, it can really differ across people. So getting sort of onset, how long have you had these thoughts? I've never had any issues in my life, and I'm all of a sudden having all these thoughts about wanting to kill myself, versus this is something that I just have all the time, and there are moments when it gets worse, and this is what happens when it gets worse. It usually either goes down pretty fast, or I kind of really obsess about it for a really long time and start to really plan and start to, my intent sort of increases over a week. And I think again, getting at sort of what that's like for each individual, and whether they're, again, really distressed by it and feel like they need to act on it, or whether it's something that they're sort of more chronic or more used to, and finding when it changes. Intent. So intent is a hard one, but it's a very, I think intent starts to get at really what level of risk that person's at. Because if you think of having thoughts as something that you're gonna, if you're thinking of individuals who are suicidal ideation is kind of like most people are gonna have some level of suicidal ideation. Where it starts to diverge is the intent piece. So the intent really sort of differentiates people who are having thoughts and really are, thinking of acting on those thoughts versus individuals who are having thoughts and are really sort of feel at that moment in time able to keep themselves safe. So intent is kind of a harder one to get to, but what kind of questions do people get at to ask about this? Or how do people assess this, I should say?
I usually ask if they understand that in their own mind it is a permanent solution to a temporary issue, and if they think about that piece of it, rather than just the concentration on the act itself.
Okay, so you start to get into sort of their, if they understand that it's more of a, like, if they were to act on it, that it's a permanent thing. Yeah, their decision is permanent. There's no going back. Okay. Okay.
I often ask, like, what would it take for you to actually kill yourself
Okay.
or to follow through with your plan?
Yeah. Okay. So asking what it would actually take for that person to follow through with their plan, or to engage in the behavior. Okay. And then how do you use that information when they tell you that?
And I kind of assess, is that situation present already?
Great. Okay. So using their kind of what that marker is from them to transition into thoughts, into behavior, and then comparing that to where they are. Okay.
How much hope they have,
Hope. Okay.
about the future.
Mm-hmm. And how does that play into intent?
Well, I believe that, protective factor would be if they're getting married,
Mm-hmm.
they got a new job. So they have something like lost their job, never happened before.
Mhm.
This is a situation they haven't dealt with, and so hope seems to be dissipating.
Yeah. So hope kind of keeps people still at that point, maybe where they're not really. If they have hope, they're really less likely to actually act.
Yeah.
Okay. Yes.
What is stopping you from doing this?
Great. That's a good one. That's a great one. What is stopping you from doing this?
I find that asking about plans or preparatory behavior and even access to needs sometimes helps flow back to the intent piece.
I really like how you said that, because the way that I'm kind of like laying it out here is that it's like, this from this to this, but the idea that it does flow and you can go back and forth between these different aspects is really important. And it also makes it like sort of more natural, like you're having a conversation with your patient versus going through a checklist of items. But yeah, that's a great one. Actually,
Oh, I think I can repeat it exactly like you said. No, I find that asking about plans, even preparatory behavior or even access to means, helps me get back to the intent piece and ask it in a more natural kind of way that flows.
if someone is like telling you that they don't really have an intent, but then when you're asking about plans and preparatory behavior, there's again some of that those implicit indicators, like they are starting to maybe give away some things, and they're starting to like think about how to, make sure their family is secure, then you can again circle back to intent in a way that, and bring that to, your patient's attention and have a really, serious conversation about that. But yeah, maybe they're not even thinking about it in that way, but then when it gets down to some behaviors, there is that implicit evidence. Someone's hand back there.
I'll ask sometimes, do they think, how well do they think they can keep themselves alive?
Yes. How well do they think they can keep themselves alive? Yeah. There's a couple of there's a study, and I know some of you may be familiar with this. It's an implicit association task. It's a reaction time task where people kind of pair sort of themselves with death, and there's a how you figure it. It's a formulation, but there's basically what they found is that it actually predicts who will go on to engage in behavior. Pretty much, it actually is better. It adds to what we already do. So we ask people questions about ideation. That gets us, to a certain point. It actually doesn't help us predict that well who's actually going to go on to die by suicide. But if you add this measure, it actually, boosts that predictability up quite a bit. But another thing that was really predictive was they're actually asking the patient, do you think you're going to go on to engage in behavior? And that was extremely predictive. More predictive than asking the clinicians, do you think that this patient is going to go on and engage in suicidal behavior? So I think there's a lot to be said about just really having, asking your patients that and sort of where they are with that. We've talked about this just right now a little bit, but when we were talking about the nomenclature, that it's not always explicit. So you need to kind of find other ways of maybe getting at this information, more of the implicit indicators of intent. Again, things around plan, preparation, if they are having, or if they're at that point of like ambivalence too. I mean, ambivalence is a huge thing with many patients who are thinking of suicide. If you can, if they're on one side or the other of ambivalence, and if there's a way that you can open up that conversation to really get at that for them. But again, finding different types of data, different indicators of potential intent. Plan and behavior. So now kind of we're moving into more like thoughts, intention to actual behaviors that people may be engaging in to assess level of risk. So preparatory behaviors is a big one. What have they done to start preparing for their plan? What access do they have? If they're for some reason they don't have access to the means that associate with their plan, are they doing things to gain access to that? Are they hoarding medications? Are they trying to get a gun? What are they doing that, again, may be sort of more indicative that they're farther down sort of the line of risk and going to more acute risk? Anything else that people can think of that would be important to ask here or plan? So the comment or question was, what if you get just a bunch of different vague answers from people, like, well, I don't know, I could stab myself, I have knives, right? There's a bridge that I could go to, but no specific plan, just sort of thoughts of thinking of different, potential ways. That in some ways can indicate just where they are. If they're thinking of kind of, just more general vague ways and they don't have a specific plan, to me that's, potentially, again, with all the other information you have, might be they might be just at less risk because they're not at that point where they've really thought through it and have come up with a plan. That's also, it's dangerous to think of it that way sometimes, because for some people it's not something that's really, really thought out. If it happens more impulsively or in the moment, it might be, whatever is available to them. I think kind of getting then to the gentleman up there said it, like, how likely would you be to engage in these types of behaviors or enact this plan? But if they don't have a specific plan, you would note that, I think, in your documentation, and use that to sort of, with the other factors, determine their level of risk. Part of, I think, what I hear you saying too is, like, are they just withholding the information? Is it more about them withholding the information or not actually having a plan?
Well, I guess I'm thinking of a couple patients who it's been I'm thinking of some people who are kind of chronically suicidal. You're trying to gauge the level of how is this different than when we talked about this 3 months ago when something else happened. and just their responses are sort of coy and kind of almost like playing this game with me, but I am trying to be serious and determine what is the risk factors, and so that's just what I found challenging in the plan section.
So, I mean, in that case, I would kind of know that this is sort of this is where they're at, and this is sort of how they've been at this whole time, that nothing's changed. It's still sort of more vague responses, no specific plan, and again, no, whatever their intent is at the moment. Because there's only, I mean, I think there's only so much you can do with the information that you're, also getting. But I think it's sort of how you then use that information, how you put it together, and how you document. Especially if it's not a change from sort of what they've been, before. Now, if they were to what would happen in a situation where they came back and maybe it wasn't, they weren't being as coy, or maybe they were actually kind of more, they were more specific, or there was more specific details related to that plan. How would that change sort of how you felt? How would that change the next course of questions that you would ask? So I think, especially as you're taking into consideration how they've been presenting to you on numerous occasions, and then how that's different than what they've done. I think that's helpful. Anything else?
I wanted to add with the plan, one is that for a timeline, at least how they conceptualize that. If they're filling out for a certain event, they always do have a claim, or they have a certain date, either an anniversary date, potential triggers, so the timeline.
Yes, absolutely. That's the very great timeline. So if someone has a plan, is it contingent? Those are some of the hardest things to just in terms of intervention, and we on our consult service will get that a lot. Well, if my house goes into foreclosure and I lose my house, then that's when I'm going to basically enact my plan. Those time limited, those time contingent ones. If my divorce goes through, I had a patient once who was like, if by the age of 30 I'm not moved out of my parents' house, and I don't have a girlfriend, and I'm not, and haven't finished school, then I'm going to kill myself. So, having a timeline, I guess, gives you an idea of just the level of acuity in that moment, depending on, what that timeline is, but it also, it can make it really, really challenging when it's things like, well, if I just get to the point where, it's all too much for me to bear, and I don't, I can't deal with things anymore, then I'm going to kill myself. Well, that, obviously is a lot more vague and can depend. And again, trying to get at that, what that would look like for that individual is really important.
Also, if they're having that conversation with family, and you say, what about your mom? Would she feel? Well, I've talked with her about it. I've kind of asked her, what would you do if I wasn't here? And, sometimes people will say, well, if you're gone, you're gone. But, that's almost like, giving them permission. Yeah. But then there are the others who say, I don't know what I'd do if you were gone. And they catch on and they're able to see it. But I've found a few, especially among the young soldiers, that they will say things like, well, I've been talking with family about it, making sure they're okay with the fact that I might not be here.
That's really important. Yeah, bringing the whole the family in, and sort of what they've been communicating to their family, and what you're sort of describing too is again kind of getting at those implicit, maybe not even so much implicit, but more explicit indicators of intent. Yeah. Another piece of that too is, and I kind of wanted to mention, in addition to the timeline, is have they started to actually, gather materials? Have they been rehearsing? So are they going, if it's something where they're going to go jump off, a bridge, are they actually going to the location, sort of working themselves up to it, so to speak? Acquired ability is this concept that Thomas Joyner talks about. in terms of like people, like they can have the desire to die by suicide, but they actually have to have this sort of ability that they've acquired, over time that allows them to basically engage in a behavior that is not life-preserving, essentially. And how that kind of happens is they habituate. They habituate to the fear of death and the pain associated with death. And how people do that a lot is sort of repeated exposure to experiences that are painful and provocative. And you could, look at sort of, this happens too with, with cutting. Like maybe it starts out as cutting and it gets over time more and more, intense, and especially as they've habituated to sort of the fear and the pain around that, it could sort of develop into sort of more serious suicidal behavior. So I think thinking about that too is like how they may have been practicing in sort of different ways, working up to that behavior. Warning signs is something that I think has been introduced sort of more, I guess recently in light of sort of suicide risk assessment. A lot of it was usually focused on risk and protective factors, which can be something that is hard because there's a whole range of risk and protective factors. And a lot of them are non-modifiable, so things like, family history of suicide, there's nothing you can do to change that. History of brain injury, it's already happened, you can't change that. So a lot of things, demographic stuff, non-modifiable, you can't intervene. They're also sort of more related to someone's risk over a lifetime versus really knowing like how that impacts their risk like more acutely. Warning signs, on the other hand, kind of give you an indication of that, like they're sort of in the near future, their risk. And there's kind of a wide range of warning signs that have been sort of noted. There's less research behind this, although there's, more being done to hone in on the ones that really are sort of more predictive of behavior in sort of this acute phase. But there's 3 that are pretty direct and are a pretty good indication that some type of intervention may be needed. So that's really communicating about suicide, telling family members, alluding to it, coming in and telling their provider that they're thinking about this, and it's either really distressing to them and they don't know if they can keep themselves safe. Preparing, actually then engaging in behaviors that either is consistent with their plan or it may not be consistent with sort of the plan that they're saying, but it's giving some indication that they're getting ready to engage in behavior, and seeking access or other means of harming themselves. These are a whole host of other potential warning signs, again, that might be related to the more acute risk. So things like, are they all of a sudden increasing their use of substances? Are they increasing their use of alcohol or other drugs? A really a huge shift in hopelessness. Are they kind of, do they have a baseline sort of level of hopelessness, but has that totally gotten to the point where they have no hope for the future? This is never going to end. I am always going to feel this way, and it's never going to get better. There's no solution. I've tried everything, and this is sort of where the individual is at. Hopelessness has been a larger predictor of suicide, actual suicidal ideation. So really getting at, it really helps you get at the sense of like whether the individual thinks that this is really a temporary thing or if it's a sort of more of a permanent thing, and then how are they going to manage that. Agitation is another one that is, I would say has a little bit more evidence research-wise. There's a few studies out there that show agitation is pretty predictive of behavior, more in the sort of acute period. So thinking about mood changes, depression mixed with agitation, that's really, that's a pretty bad combination. So especially if people are increasing their substance use as well. So how are all these playing in together? And again, how are they different than sort of how the patient is normally presenting, or sort of what we consider their baseline? Sleep disturbance. Sleep is a thing that is, again, is I feel like it comes up over and over and over again in relation to a lot of different sort of psychiatric and medical conditions, but it has a huge impact on individuals, obviously, but insomnia, nightmares, those are actually have been independent predictors of suicide. So if you have all these things and they're not sleeping well on top of it, so maybe that's a way that could be a potential, like one of the earlier interventions that you could do to get people's risk down. But it's also something that people can like target more upstream or ahead of time before people get to the point where they're really suicidal. So there's a lot of research actually being done to look at that individually. So now that you have information on sort of more direct warning signs, whether they're having thoughts of suicide, what their intent is, whether they have a plan and access, what are some other things that you want to sort of add to that formulation to actually help you determine what level of risk they're at? So this is where risk and protective factors come into play. So a person can have a lot of risk factors, but they have a really great support system. They're working right now. There's psychiatric disorder. Their depression is stabilized. They're engaged in treatment. I mean, those things can really sort of modify your determination of their risk level. So you want to, take all this into consideration. Other risk factors as well, including just there's a lot of psychosocial risk factors. So what are they in the middle of like a divorce, or is there a lot of conflict in their relationship? Is their housing stable? Are all these other sort of like basic life needs stable? I think for a lot of our OEF, OND veterans that are coming back, it's really interesting because I've talked to a lot of providers about this too, and the OEF clinic down sort of where we're at. And when they present, a lot of times they're presenting not about, I'm having PTSD symptoms or this and that. They're presenting about sort of kind of more basic things that they need in their life. Like, I need, a job. How am I gonna, take what I transition out of the military? What am I gonna do now? How am I gonna provide for my family? It's sort of these more immediate things that we, I think in the VA have struggled to sort of think about how we can give more immediate solutions to our veterans for these problems and how to keep them engaged in treatment long enough to where we can see a difference in these. But those are the sort of the things that we're seeing a lot that they're presenting with initially. Any other risk and protective factors that really stand out to people besides psychiatric illness, management of psychiatric illness, substance use? Those are sort of the things that we typically always evaluate anyway, but then how you use that to sort of formulate where that patient is in that moment in time.
People often talk about pets.
Yes, it's a great one. Pets as a protective factor. I've actually had veterans say that they wouldn't kill themselves because they couldn't. They have to be alive for their dog or cat. Yeah.
With respect to the risk factor that we struggle with in the geriatric population, it's the lack of sense of purpose and hopelessness, and it's so pervasive.
Yes.
It's really hard to address.
Lack of sense of purpose and hopelessness. Reasons for living. Yeah, we're gonna, there's actually, when we get into the section of like how we can augment sort of risk assessment with specific measures, we have a reasons for living measure that we're gonna talk about. But I think a lot of people, they also, when they're sort of in that state, it's hard for them to think about reasons for living. But if you sort of assess it in a way where you kind of get at sort of different, potential options or different reasons of living for people, they may actually realize, oh, okay, there are some things that, that I am staying alive for. So I think it's also giving people, and I think that's how measures can really augment risk assessment, and that they can sort of get at different nuanced information that people might not be able to think of on their own. spiritual connections. Thank you, that's very important, yeah. And I think that's sometimes an area that clinicians sort of stay away from, but can be very, very important in terms of both risk and protective factors, but particularly protective factors.
As a risk factor, sense of burdensomeness?
Yeah. Yes, absolutely. Sense of burdensomeness and yes, failed belongingness. So how connected are they? Do they feel like their existence is a burden on others? By being alive, they're actually burdening others. And oftentimes that's, a perceived, it's perceived, but there could be some reality to that as well. So how do you deal with that? And then failed belongingness support system. That's, again, very, very important. A lot of evidence showing that the lack of social support isn't as detrimental as negative relationships. So I think thinking about that as well, what is the nature of the relationships and what resources do they have? Employment.
Is the efficiency or effectiveness of treatment.
Yes, okay.
Because a lot of times they're like, this is the third time I've been doesn't work, and just letting them know that sometimes it takes 3 or 4 times.
Yeah, so keep being engaged in treatment engagement. Yes, it's a very, very, that actually is, especially for individuals following psychiatric discharge, that is a really high-risk period for suicide for a lot of people, and one of the things that is related to that is just lack of treatment engagement. So those that are more engaged in treatment, lower risk of suicide than those who aren't. These are all good. These are all great responses. Just like we had mentioned before that a lot of risk factors are non-modifiable. It's good to know. I mean, it's good to know people have a family history of suicide and different, gender, age. I mean, we know that can sort of help in some ways just know who over the course of a lifetime is at risk, but it doesn't really give us anything to work with in terms of like intervention and treatment. So we really want to be honing in on some of those risk factors and protective factors that we can potentially change. And that are really, I think, most important or most distressing to that individual. So things like managing mood and managing depression, is that, those underlying illnesses and diagnoses, are those being well managed? Treatment engagement, very critical. What are some ways that we can increase treatment engagement? Can we be creative about that? Are phone calls in between appointments, little brief check-ins, effective for some patients versus, if they're missing a lot of their appointments, are they more responsive to doing really quick check-ins and phone calls with you? I don't know what it's like here, but I know that something we struggle with in our facility is just like the time between appointments. Are there things that we could be doing to sort of help buffer, again, those like maybe quick contacts, just to let people know that we're thinking of them, it helps them stay connected, that we could do to sort of again make sure that treatment adherence over time is as high.
This also makes me think about some of the potential negative consequences of not being realistic with veterans about whether treatment will work or what treatments will work for them. And so if you're not sort of paying attention to that, sending them to a treatment that they're not ready to engage in gives them a failed treatment. And that can be really detrimental in the long run. And so I think this speaks to trying to match them with what they're ready for. And also being realistic, like if they really need PTSD treatment, they're like, nah, I'd rather just do this 3-session sleep thing. Telling them, that may help on these levels, but ultimately you may need to find that you need more, and so helping them to pick treatments and engage where they're ready. Because again, the failed treatments, which doesn't mean it will always fail, but those weigh heavy on that, I think.
Medium. So I will try to repeat what you so eloquently said, and I'm not going to do as well of a job, but basically meeting people where they're at, and that kind of really goes into some of the intervention stuff too. If you think what is indicated as PTSD, CPT or evidence-based PTSD treatment, but they're not ready for that, maybe they're ready to target their sleep. Can you meet them where they're at, and at least that can increase maybe the likelihood that they will stay engaged and continue. But also being very realistic with them up front about, like, these are treatment options. This is what you can expect in treatment. Sometimes things get worse before they get better, and having sort of an ongoing conversation with your patients about that. And that can, I think, not only just help with the therapeutic relationship, but can really give them a sense of, maybe control, expectancy, and maybe not contribute just level of, like, as much hopelessness if they know that there are other options if this one doesn't work.
One of the things that we did with our rural patients was that when they came for a visit, we had them fill out a postcard, and on the back of the postcard it would say, "Hey, how you doing? You have an appointment coming up on this day, and we're looking forward to seeing you." And the clinician would sign the postcard, but the patient would address the postcard.
That's a great idea. I love that one. That's really great. Did everyone hear that? I don't know if everyone can hear that, but having the patient actually, when they're in session with you, address a postcard sort of from you that's basically saying, I hope you're doing well, can't wait to see you on your next appointment, and having them address it, and they get that in the mail. It's sort of connected to your session, and then it's another sort of something like tangible that they can get. Yeah, bridges it. Yeah, that's great. Back there, there's someone has their hand up back there.
I think sometimes we're certainly agitated or patients focusing on that notion that I can hold what you got, that you can be afraid, you can be overwhelmed, but I've got you. You'll learn and it's going to be a very holding environment. Focusing on that sometimes can be a
That was beautifully said. Just having a place where people can, feel the way that they do, that you're giving them the message that you can hold that with them, and you can be in this place that's scary with them, and very uncertain, and that it's like willingness. Like, are you willing I'm willing to be here with you, and I'm willing to work with you. Are you willing to, trust me and work with me to, like, help find ways to keep you alive? And I think a lot of times when people come in, and I think this is something that, acceptance and commitment therapy really tends to hit hard, is like, can you get people just even willing to try something different? And let them know that you're, like you said, in it with them. And then what does that look like? And how are not only your words, but your behavior, everything that you're doing, communicating that message to people? Thank you for all these really great answers. I'm going to have to write some of these down for the next time we do this. So a lot of times we, as clinicians, we're used to asking some of these questions. Certain patients are, it comes easier. Other patients are more difficult. There's a lot of variability. We have our ways of doing things, and we kind of change is it's hard a lot of times. And I think there's a lot that we can be doing, a lot of tools that we can be using to sort of help us in sort of what is a very, I think, challenging and difficult task. And that is measurement, using measures that are out there that are feasible to use in practice. We're not talking about like full-scale psychological evaluations here. We're talking about sort of brief, structured self-report measures that have been validated, that are valid, that are reliable, that we can use to sort of maybe get at some of these areas that we're trying to assess, and that we can easily then incorporate into our formulation and our documentation. So this is, again, the caveat that they should never be used alone, that clinical judgment and clinical assessment is the gold standard, and that these, however, can help augment your assessment, and they can actually, if you're giving them on a repeated basis, they can sort of like show you how things are changing. So, you know, it can help you determine like what is an individual's baseline level of ideation. Okay, if they're always at sort of this mild to moderate level, you know, how is that changing over time? So if they come in the next session, you see a spike, what is that about? And really trying to hone in on that. And then if it's pretty, you know, stable and other things in their life are stable, again, that's their level of risk, their acute level of risk likely, you know, is not going to change, and your formulation is probably not going to change that much. But these can really help get at sort of different types of information that maybe you normally wouldn't ask. So we use a number of different measures in our consult service, but these, I think, 3 are really the ones just to, I guess if you were to pick any 3, these are the 3 that we would really pick. Beck, the BSS, or in CPRS is actually the BSI, Beck Scale for Suicidal Ideation, really gets at different sort of aspects of ideation, and it gets actually into plans of preparation as well. So that's why it's really nice. It starts out with 5 items, and depending on their answer to the 5 items, they may not have to take the rest of the items. So if it's kind of like a built-in screening, which is kind of nice too. So if they don't respond positively to, I think, items 4 and 5, then it just closes out the assessment. And then if they do answer positively, it goes into a lot more detail about the nature of their ideation. It takes 5 minutes to give. You can give it, I mean, you can pull it up right in CPRS. I'm actually going to walk through an example of that. The hopelessness scale, which a lot of people have referred to, that's very important to look at as well, is also in CPRS, also takes 5 minutes. It's true and false, 20 true and false item responses. They run through really quick. Again, really nice to sort of see how that changes over time and to track that on an ongoing basis. It also helps not only in terms of assessing risk over time and looking at that on an ongoing basis, but like, are your interventions, is your treatment working? Are these going down? Are they kind of just, you know, more stable? And I think it gives you sort of a lot of different types of information. And then as far as protective factors, it's totally cut off here, but the reasons for living inventory really gets at sort of different potential reasons of living for individuals, things from family, relationships, to you know, spirituality and religion, things that are just related to just a person's desire to, you know, this idea that they know kind of maybe that things are going to get better, they may not always be this bad, and sort of it can be broken down sort of a different component. So it's really nice because it's like, okay, this, you know, family is the only thing that's keeping this individual alive. It's their only reason for living. And then something happens, you know, in those relationships. That would be a really huge trigger for you as a, you know, a provider that their level of risk is likely going to go up and increase, and what can you do then around that? I'm sorry? Yeah, in our consult practice, we tend to use both. Yeah, I may just usually give it to them. And the way that you do this is also, a lot of times I will, if it's a new patient, you know, I don't just give these to them right off the bat. I will go through more of my clinical interview, and then I'll augment it, you know, with giving these measures. If it's someone that you're seeing sort of on a regular basis, you obviously establish a relationship with, and sometimes it might help just to give the measures, like make it like almost a routine thing that you do. They come in to your session, they take, you know, like 5 minutes of measures, and then you look at the measures and you hone in on how is this different than, you know, last week or last time we met? What's going on? Why is it different? Honing in on specific items, like, whoa, this one, up until now, this individual is saying that I think I'm confident that I can keep myself safe, and now it's dropped to I am unsure that I can keep myself safe. Again, that gives you sort of a way to sort of pinpoint and hone in on specific things in the assessment process. we've kind of gone over this, but you know, one thing that, again, kind of going back to that individual that has more chronic risk over time, and is maybe their level of ideation is always like at a moderate range, and you may see that and you're like, oh my gosh, that's like really, that is this person might be at high risk, or they've got. They're saying that they're having really severe persistent thoughts of ideation, all the time. And what you do with that decision may differ if that's sort of the norm for the person and they have all these other supports in place that are, really sort of driving that level of risk down. So it kind of prevents you from, making decisions that, again, sort of violate autonomy. Really kind of helps you keep sort of to what that looks like for that individual versus kind of having this, score on 15 doesn't mean the same thing for, everybody on a measure. And we're actually gonna look at that here. But if someone's never had a history of ideation and they've never really had any issues and they're coming and they're scoring kind of in the mild to moderate range on ideation, there's a lot more that you want to be looking at there, and a lot more information you want to be gathering to really see where they're at. So how many people have used either of these scales through CPRS? The BSS or the BHS? I think I saw one hand. Okay, all right, yes, that's great. Okay, it's really easy, and it's there, and you can, I'm gonna walk you through just sort of how you get there, and then how you can use the information in terms of documentation. Actually, we're probably gonna get into more of the how you use that information in formulation and documentation after lunch. But here's the first part of it. So mental health assistant. Do people know what that is? Yeah, okay. So go into mental health assistant, and then you're basically going to go to instrument administrator. And this is all pseudo patient, by the way. This is a pseudo test patient, so this is not someone's actual record. So I'm the interviewer because I'm going into signing in as myself. I'm going to scroll down. Look at all the. I didn't even know that they had the AAQ in there. They just put that in there. So you can scroll down to the BSI and click on the measure, and then I usually you can hit patient entry. Or staff entry, but basically if you do patient entry, usually just one question at a time, and it blocks the person from being able to get into other parts of the record and stuff, because usually have them sit at the computer and take it. So one question at a time, so it's not a bunch of questions, and this is all a matter of preference, but I find it usually easier for patients just to concentrate on one question at a time, and it just sort of then takes them through it. You do patient entry, and then it will have one question at a time. So this first question on the back is basically select the one statement in each group that best describes how you have been feeling in the past week, including today. So the time frame for the back is also it's nice and short, so we're not looking at, have you ever had suicidal ideation in the past year, month. I mean, it's really kind of honing in on sort of more of a current time period. So they basically select their response that best fits how they've been feeling. They hit next. And then when you're finished with it, it basically gives you the option of how you want to sort of save this information into their medical record, because it creates a template already, and it just saves it in the medical record. So I want to save this as just a standard progress note. So it saves it as a standard progress note, which is basically, it has all the responses listed in a total score. So here you see all their notes, and that it's on the top, saves it as a note. The local title is mental health diagnostic study or test, and then here are all the responses. and the total score on the top, which I'll get into on the next slide. Okay, so here it says the BSI score is 15 and indicates low suicidal risk. So this is the one caveat that I'm going to say to using this, and this is actually something that they recently added. It didn't do this determination level of risk before. Don't pay attention to the determination level of risk because that is not the standalone thing that you can use to determine that. Although it will give you an idea of sort of where they're at in relation to sort of the norms of the scale. Like the 15 would be, is considered sort of more of the lower range. It's 19 items. It's ranges from 0 to 38 is the score. So 15, let's see where that is in the range. But what I then do is I go through the items and I look at things that stand out to me. Okay, so I have a weak desire to kill myself, okay? The other option is I have no desire or I have a strong desire. So middle range. And then I want to look at sort of red flags or things that are really catching my attention. So I am sure that I can keep myself safe. And I am sure that I shall make a suicide attempt. So things, again, options for those, or I will make a suicide attempt, or I am sure that I can keep myself safe. So how are those sort of things going to play into things like intent and their overall sort of ability to keep themselves safe? There's a lot of things related to plan and preparation. So item 16, item 16, 17, and 18 all have to do with preparatory behavior. So I've made no preparations, I've written a suicide note, or I've made no arrangements. And actually, interestingly, it gets at a question that asks whether they try to hide their desire for engaging in suicidal behavior from others. So these are just the different items that you can really hone in on, and then I actually will be like, and I'll take, their responses and I'll be like, I just wanted to go over a few things with you that I noticed. I just want to check in with you about them. And I'll go through ones that, seem more concerning to me. And a lot of times I'll get, clarification. And if there's a point of clarification that I'm getting, then when I'm documenting, I'll include this score in there. I'll make my assessment of like what level of risk, and if there's a couple items that if someone were to like read it, they'd be like, well, it's here. It's saying, that it's, it doesn't sound like a low risk. It actually sounds like they might actually go on to, engage in suicidal behavior. I'll note, followed up with a patient regarding, item 16 and clarified there is no intent, just based on the response. So really, again, paying attention to, it gives you sort of an overall score, but if there are particular items that are sort of concerning, if you're going to be using this measure, you really do need to, again, clarify how it's sort of playing into your determination of risk. So that is, that's the example from the BSS. I would say if you had to choose one measure because you just don't have time, this is probably the one that I would choose because it does get at a lot of different, it gets at aspects of ideation, it gets at aspects of intent, it gets at aspects of plan and preparation. So a really good one to augment your clinical interview if you had to choose one.